Okay, just wanted to take a little bit of time here to recognize the fact that there are some other endocrine conditions. It's not just about diabetes, and this obviously is a shorter slide set. It won't take as long because this probably isn't as big a part of your world, but there are a few things I want to point out, and they're mostly about the pharmacology of managing thyroid diseases. We're going to mention adrenal disorders for just a minute, but I want to focus on thyroid disorders mostly because that's the second most common endocrine thing actually that you see. Okay, so the first one we're going to talk about is hypothyroidism. You know that hypothyroidism is a condition where you do not have enough circulating active thyroid hormone on board. There's a lot of reasons it can happen. It can happen because the thyroid gland is not being stimulated. It can happen because the thyroid gland itself isn't working right. And there's a bunch of little other oddball things that can happen too. But most of the time, patients have an autoimmune condition where they make autoantibodies that block the actions of their thyroid gland. So their thyroid gland wants to work, the pituitary is stimulating it, but these autoantibodies are in the way. Let's see what your slide says. This hypothyroidism is the most common thyroid disorder. Yes, more common in women than men because it's usually an endocrine problem, or endocrine. It's usually an autoimmune problem, and autoimmune disease generally is more common in women than men. Also, just as an aside, if you have one autoimmune disease, you're more prone to have others. So patients who have other autoimmune things like lupus or rheumatoid arthritis or inflammatory bowel disease or psoriasis, they're all at higher risk of hypothyroidism anyways. Hypothyroidism can be primary or secondary, meaning, like I said, the problem is the gland itself or it's related to something else and the gland is fine. It also can be a consequence of other pharmacotherapy, and we'll talk about that for just a minute. The bottom line, though, is wherever it comes from, if the patient is clinically hypothyroid, medication management is replacing thyroid hormone. There's another bullet point here that says it's frequently a consequence of curative therapies for hyperthyroidism, and that's true because the best curative therapies of hyperthyroidism are ablation of the gland, radioactive ablation, or surgical resection, and it's almost impossible to do that perfectly. So what usually winds up is the patient swings in the other direction. They go from hyperthyroid to hypo, and that actually is preferable because with hypothyroidism, we can manage it better. We can just replace the hormone. But like I said, the most common cause is autoimmune. Okay, this picture just points out to you what kind of symptoms you can expect in somebody who's hypothyroid. Thyroid hormone is the hormone that sets the metabolic rate in the body. It sets the timing. Everything that happens in your body is according to a time frame, right? The heart is supposed to beat 60 to 100 times a minute. Your bowel is supposed to peristalse at some rate, and I don't know what it is, but at some rate that allows you to have a bowel movement and excrete your non-absorbable intake once a day. Like, oh, if only that would happen. What you're supposed to sleep, your metabolic system should be aligned that you sleep between 8 and 8 hours a night for optimal rest. I mean, everything is supposed to happen according to a time frame. It doesn't always because other factors interfere, but thyroid hormone is an important part of that. Thyroid hormone sets the metabolic rate. Whatever is supposed to happen in your body, part of that time clock is due to thyroid hormone. So if you don't have enough thyroid hormone, if you're hypothyroid, everything slows down a little bit. There tends to be like some weight gain, mostly from water. The circulation is not as efficient. People tend to get like cool, sluggish skin. Skin cells don't turn over fast enough. So usually our skin cells turn over like every 5 to 7 days. And that's why we don't have a bunch of skin that's all dry and rough because, skin gets damaged by soap and water and dirt and the environment, but every 5 to 7 days our skin cells turn over, we get new skin. But if you're hypothyroid, that doesn't happen quite right. Just everything, even your period, like menstruation tends to be longer in patients who are hypothyroid because endometrial turnover is not as efficient. These patients are often constipated because their bowel doesn't peristalse on time, their heartbeat is slower, so they may be have a sense of fatigue. Everything just happens slow. So the treatment is We want to replace the thyroid hormone. Exogenous replacement of hormone is the only available treatment. If there happens to be like some abnormal cause, I shouldn't say abnormal, but less common cause where you actually can cure the cause, well, then that's what endocrinology does. But most of the time, it's just about replacing the thyroid hormone, and administering that hormone is what you will be doing. There are two primary forms of thyroid hormone that you administer as a nurse, and they are T4 and T3. T4 is levothyroxine, and this is marketed as like Synthroid and Levoxyl, and there's all sorts of brand names for it. This is the most common one, and probably most of you at some point have given levothyroxine. This is T4. T3 is also available pharmacologically. It's called Cytomel. And the reason that you don't see T3 given as often is because it is the metabolically active form of thyroid hormone. So if you give it to somebody, it's like you're giving them something that's very potent to speed up their metabolic system. We don't usually, we as a healthcare community much less often see people given T3. Liothyronine is a generic name, and like I said, this is marketed as Cytomel. But most of the time, what you will give is T4, which is levothyroxine. And the reason for that is that T4 in its own right is not as active. T4 is considered the less active form, and what you do is give it, and then the body converts it to T3 by deiodizing it. T3 is tyrosine with 3 iodines on it, and T4 is tyrosine with 4 iodines on it. And so, you give the patient T4, which isn't as active, and when the body needs active thyroid hormone, it will deiodize the T4 to T3, and then that's more active. So T4 is just a little bit easier to control. You're less likely, and not that you can't do it if you bombard them with an overdose, but you're less likely to make patients hypermetabolic with T4. T3, on the other hand, is active when you give it. There is no deionization, so the side effect profile is more significant. Always, the primary safety issue when you are giving a patient thyroid hormone is the potential for over-medication and toxicity. So think about what will happen. Think about the things that you're watching for in your patients and you're teaching them about. If you're concerned about an excess of a medication that speeds up the metabolic rate, then the signs and symptoms would be everything going too fast. Tachycardia, the blood pressure goes up, they start to lose weight. Hypermotility of the bowel. Patients that have too much thyroid hormone on board usually have a couple of low volume stools a day. They do tend to get hypertensive, a little tremulous, tachycardic, even to the point sometimes of palpitations and angina. Sometimes they feel like they can't sleep. They're just sort of like in metabolic overdrive, right? They're like hypermetabolic. Those are the things you want to teach them to watch for, and those are the things as the nurse that you want to be on the lookout for. Especially when people are hospitalized. Because they're sick, their body chemistry changes quite a lot. And we usually, when we hospitalize people, we keep them on the same medications that they're on as an outpatient. So it's not at all unusual. Somebody's been taking like 125 mics of levothyroxine for the last 5 years. And then they get sick and they come in the hospital and they're just admitted on the same outpatient drugs while they're being treated for whatever they're treated for. But when body chemistry is different, the patients may have greater or lesser responses to thyroid hormone. They might be given other drugs that interact with thyroid hormone. And the bottom line is, even though they've been on this dose for years, now in the hospital, it might be too much for them in combination with everything else that's going on. So for you, like the implication is, watch for those patients with those heart rates that are suddenly accelerated. Like when the patient got admitted, for the first day or two, their heart rate was solidly in the 60s. And then you start to notice maybe it's solidly in the 80s or 90s. Like, why is that? Too much thyroid hormone, thyroid toxicity is what we're talking about, really, is totally a potential for that. And then ask yourself, remember I said T3 is metabolically active, T4 has to be deiodized. So which form is more tenuous? It's the form that you don't use and excrete right away. T3, you will, if you give it to the patient, they use it, they're hyperthyroid, and then they metabolize and excrete it. But T4, because it doesn't get converted to an active form right away, I'm having word finding difficulties. It flows. There's a word I want, I can't think of it. But it kind of cycles around blood just waiting to be deiodized. And if for some reason things change, it may stay on board for a much longer time, and then the patient keeps taking a daily dose, and before you know it, it's like they've got a lot of thyroid hormone in storage in their body. And if it all activates at the same time, then they become thyrotoxic. With respect to patient education, another thing you want to teach people about is, well, always, I was going to say especially if it's new, but not just if it's new. Anytime you have a patient who's taking thyroid hormone, one of the things you want to counsel them about is the fact that thyroid hormone in the gut is like, it's really easy to bind with other stuff. So if you take it with other foods and other medications, it really can make a difference in the way that it works. Like if you're starting somebody on it in the hospital and you can control the way it's given, so you know it's being given on an empty stomach. But if nobody mentions it and they go home, a lot of people tend to take their pills with food. They feel like they go down easier, they feel like they don't have as many side effects or whatever. So you have somebody who has started on a dose on an empty stomach and was doing fine, and then they go home and start taking it with food, it is going to be less well absorbed. So you always want to remind people that thyroid hormone ideally should be taken on an empty stomach. In a perfect world, should be separated from anything else by 2 hours, although that's really hard to do in real life, but at least an hour. And the other thing is that it should be taken with a full glass of water, because that really facilitates GI absorption. Now, the flip side of being hypothyroid is being hyperthyroid. And actually, the proper term for having too much active thyroid hormone in the body is thyrotoxicosis. You're toxic of thyroid hormone. And this can happen for any reason. Thyrotoxicosis is any clinical condition where the patient manifests too much thyroid hormone. It could be because their gland is overactive. It could be because there's a tumor or a nodule on their gland that's producing hormone. It could be because they're taking too much thyroid hormone. For whatever reason, if there's too much thyroid hormone circulating in their body, they are said to be thyrotoxic. And then the adverse effects are what we were just talking about of taking too much thyroid hormone. Everything moves fast. GI motility cranks up. So they're going to the bathroom a couple times a day. Blood pressure tends to go up. Heart rate tends to go up. Calorie burn increases. So there is often some degree of weight loss. Some people are just so hypermetabolic, they actually get a little tremulous, so they feel anxious all the time or have trouble sleeping. The periods tend to be very short. There's like a 2 or 3 day, scant amount period. Everything just tends to go a little bit too fast. People who are thyrotoxic often look like they're moving when they're not, like just sitting there. There's sort of a tremulous quality about them. Now, hyperthyroidism is a more specific term for when the thyroid gland itself is actually hyperfunctioning. So you can be thyrotoxic and not hyperthyroid, if that makes sense. So in other words, if the patient is put on thyroid hormone as a medication, because they're hypothyroid, but the dose is too high for them. And when they show back up for evaluation, they're thyrotoxic. Everything is moving fast, like we were just saying. That is the patient who is thyrotoxic, but they're not hyperthyroid. The patient who's hyperthyroid has a thyroid gland that is overfunctioning. They're making too much thyroid hormone and excreting it in their body. So here's the way thyroid hormone is produced, and the way you look at this, let's see if I can label it here. So this whole big thing on the screen is the thyroid gland, right? So let me see if I can draw a red circle, or not a thyroid gland, but rather a thyroid cell. Glands are made up of a bunch of cells. So what I've got outlined here in red is a thyroid follicular cell. And what's going on is that iodine is being pumped from circulation. I'll label that as 0.1. Let's see if I can circle it to make it stand out. Yeah, there's 0.1. Iodine is being pumped from blood into the gland. And you see the arrow going in, right? You're pumping iodine in. Iodine gets pumped through the thyroid follicular cell all the way deep into the thyroid gland, where I'm putting this arrow from the number 1. The iodine gets pumped all the way deep into the gland. At the same time, in the thyroid follicular cell, the endoplasmic reticulum is synthesizing thyroglobulin. And thyroglobulin is, and that's going to be 0.2 here, Thyroglobulin contains tyrosine, and tyrosine are the amino acids that complex with iodine. So deep inside the cell here at point 3, the tyrosine is complexed with the iodine. This is called iodination, and it makes tyrosine iodine complexes. And if it's a tyrosine and 1 iodine, it's T1. If it's a tyrosine and 2 iodides, it's T2. And that's what it makes deep in the cell. And then so you'll have monoiodotyrosine T1 and diiodotyrosine, which are T2. And then they will come together in various assemblies to produce T3 and T4. And that's what's happening at point 4. Back in the thyroid follicular cell, the tyrosine with the iodines are complexing together and making T3 and T4, mostly T4. 90% of the hormone that this gland makes is T4. And then it stays stored here in the thyroid gland at point 5 until there is a stimulus to release the thyroid hormone. And then T4, mostly, and a little bit of T3 are then separated from the thyroglobulin and sent out into circulation, and that's going to be 0.6. And so when we say somebody's hyperthyroid, this is happening too much. Too much of this is going on. So this is one way to get too much thyroid hormone out into the body, although there are others, like I said, like somebody who's taking too much hormone. And people do abuse Synthroid. They use it because it makes you hypermetabolic, so it makes you lose weight and have more energy and sleep less, and it is a drug of abuse. All right, so that's the way the gland works. So if you're hyperthyroid, that's happening too fast. And if that's happening too fast, you've got Graves' disease. Graves' disease is true hyperthyroidism. And this also is an autoimmune condition. So it's also more common in women. And this is the most common cause of being thyrotoxic. So again, I'll say it one more time. Thyrotoxicosis is when you have too much thyroid hormone in your body. Hyperthyroid is when your gland is overproducing it. And the most common cause of that hyperthyroidism is when you have Graves' disease and you make autoantibodies, and those autoantibodies, and they're called TSIs, thyroid stimulating immune globulins, and they actually stimulate your thyroid gland and make it work. Make it work in overdrive, so the gland is overfunctioning. Now, some of you are probably familiar with Graves' ophthalmopathy. This is when patients sometimes get exophthalmos when they have Graves' disease. And this is the only form of thyrotoxicosis that you get exophthalmos with, because that ophthalmopathy is also autoimmune mediated. The same autoimmune disease that makes those TSIs that stimulate the thyroid gland also makes ocular muscle antibodies that causes hypertrophy of the ocular muscles, and that's what makes the eyes exophthalmos. So if you're hyperthyroid for any, or I should say, if you're thyrotoxic for any other reason, you won't have exophthalmos. This Graves' disease is not a transient condition. This does need definitive permanent treatment that is curable. And this is something that, unless you work in something like interventional radiology or you work for an endocrinologist, you won't deal as much with the curative business of Graves' disease, but you will be administering medications that are ordered to help people for symptom control. So, let's see, Graves' disease treatment. Presentation, they usually are symptomatic. They're symptomatically thyrotoxic. They are tachycardic, palpitations, tremulous, weight loss, can't sleep, all that kind of stuff. And the medication of choice for symptom relief, this is the one that you will virtually always be administering to people with thyrotoxicosis, is propranolol. Because propranolol is marketed as Inderal, you probably know it. It's a non-cardioselective beta blocker, and it slows down almost all of those symptoms of thyrotoxicosis. Remember, everything is happening too fast when you're thyrotoxic. And propranolol blocks beta receptors, and beta receptors, remember, are bound by epinephrine. They activate everything, so propranolol blocks it. So it calms down the heart rate, calms down the tremor, slows the blood pressure, slows down the gut, slows down the anxiety, helps you sleep. Propranolol. That's the symptomatic treatment for everybody. Curative choices are just listed here, FYI. Radioactive iodine for ablation of the gland, and that's a very specialty thing. They'll go to interventional radiology for that. And then they just calculate tracer, like they calculate doses and then just ablate the gland. Certain patients get treated with antithyroid drugs, and again, that's very much a kind of a specialty thing. I guess I should mention what antithyroid drugs are, but I thought we might talk about it in a few minutes here. I'm sure we will. So let's see, what else? Graves' disease. Not everybody is a candidate for radioactive ablation. That's very true. Yes, patients with mild forms of disease will benefit from antithyroid drugs. And like I said, we will talk about antithyroid drugs in a minute. And obviously, surgery is the treatment of choice in pregnant women because you can't ablate their gland. Surgery is a treatment of choice for women who don't respond to antithyroid drugs like PTU. Another cause of thyrotoxicosis or thyroid excess is an adenoma. It's a nodule. There's single adenomas, and these are called autonomously functioning thyroid nodules or AFTNs. And then some people have multiple nodules, and this is toxic multinodular goiter. This isn't Graves' disease. It's not autoimmune. There's no antibodies involved. These patients just need to go to surgery and have those things cut out. Autonomous thyrotoxicosis treatment. Okay, so this is what we were just talking about. I hope this slide says the same thing I just said. Treatment depends clinically upon the status. Yes, if the patient is euthyroid, they can just be watched. But you know what? For symptomatic nodules, the patients typically get operated on. But I want to talk more about the drugs. Let's see. Toxic multinodular goiter. Now, because there are so many goiters here, like there's many nodules, you can't really go around cutting these all out. So these patients are referred for radioactive ablation. And from a patient education perspective, I mean, patients who get radioactive ablation, they need lots of education about managing their waste products and stuff after they are irradiated. But again, that's pretty much a specialty service. The point being, autonomously functioning toxic nodules, if they're symptomatic, they typically get operation. Toxic multinodular goiter, if they're symptomatic, they usually get radioactive ablation. Subacute thyroiditis. This is the last thing I think then we will get to the drugs. Subacute thyroiditis, this is also called de Quervain's thyroiditis. This is a patient who is thyrotoxic, but not for any other reason except that their gland got excited and it started releasing a bunch of hormone. Remember how we were looking at that diagram and I said the thyroid gland stores the thyroglobulin with T3 and T4 in it, and then when the gland is stimulated to release it, the T4 and T3 come out. And that's true. And if you're hyperthyroid, that's all happening too fast. And if you have a goiter or if you have a nodule, then the nodules are doing it. But some people don't have any of that. Some people just have thyroid inflammation, thyroiditis. And what happens is that something has happened to the gland to excite it. Usually viral in origin, and the gland gets inflamed and it just spills out all that stored hormone. So the implication is you don't want to do anything with the gland because the gland itself isn't hyperfunctioning. It doesn't need any defined treatment. It's just that the patient gave itself a thyroid bolus, probably from a self-limiting viral infection. So all we do is just, be watchful of the symptoms of thyrotoxicosis. And these people either don't usually need any medicine at all, or they will need propranolol to help with the symptom control. And then because the body always tries to regulate itself, a period of hypothyroidism typically does follow, and then the patient will get back to normal. So I mention these different things just so that if you ever see people getting treated in different ways, like this one has to go to radiology and this one needs surgery and this one just needs a beta blocker and nothing else, like, what's the deal? Why is that going on? And this is exactly why. Virtually everybody who is symptomatically thyrotoxic for any reason, Graves', nodules, or subacute thyroiditis, they need symptom management, and that's going to be with propranolol. Sometimes you'll see people use other beta blockers, but a beta blocker, I guess I should say. If it's somebody who has truly Graves' disease, they need interventional radiology. If it's somebody with a single nodule, they're the ones that are going to get a surgical consult. And subacute thyroiditis, they're not going to get nothing. All they're going to get is propranolol. We manage their symptoms, then we wait, watch them go through their hypothyroid phase, and then expect them to go back to normal. And so with all of that in mind, let's look at some of these drugs. So like I just said, treatment of subacute thyroiditis is self-limiting. These patients get beta blockers for symptom control. Sometimes when it's really, really bad, and it's usually not, you'll see people give short-term iodine therapy, like in the form of Lugol's solution. That's one of those things you've probably heard of and never seen. Lugol's, excuse me, Lugol's solution is like straight up iodine. And the reason we give that to people who need really short-term symptom management is that if your gland is really, really overfunctioning really bad, but it's not permanent and you don't want to do any permanent treatments like surgery, if you blast the gland with iodine, remember we talked about the pump and how the gland pumps iodine in? Well, the body is always protecting itself from toxicities. If you throw a bunch of iodine at the patient, those iodine pumps that pump iodine into the thyroid follicular cell will shut down. They will know that the gland is getting ready to be overstimulated, so they shut down. And that shuts down function of the gland. And that's how giving somebody a bolus of iodine can shut down function of the thyroid gland. And that's what we do sometimes in subacute thyroiditis if it's really, really bad. But most of the time, that's not what's going on. Most of the time, it's just symptom control with beta blockers. And probably, if you don't remember anything else about any medication for managing patients who are hyperthyroid or thyrotoxic, just remember that the beta blocker is going to be the drug of choice. Propranolol is really the prototype one because it's not cardioselective, so it hits beta blockers all over the body. Atenolol is a more cardioselective drug. If the patient has contraindications to a beta blocker, like they have poorly controlled asthma, then you might go for the atenolol because atenolol is just cardioselective, so it's only going to help control the cardiac symptoms of hyperthyroidism, but of course they're the most important ones. And again, it's just symptom control. It doesn't impact the gland at all. And these really are appropriate for people who are thyrotoxic for any reason. Now, the iodines, we just talked about that. I mentioned Lugol's solution. There are a couple others here. And basically, you are just totally blasting the gland with iodine, and it shuts it down. It will shut it down to protect itself. And that's it. And it can. I mean, it's usually not used for several months, although apparently it can be. This is usually, I've never seen this used to treat subacute thyroiditis, but I have seen it used to slow down thyroid function in patients who are going to have a thyroid operation. So it'll be given to them like a week pre-op to slow down function of the gland so that when they operate on the patient, they don't throw them into a thyroid storm. Excuse me. The antithyroid agents, I kept alluding to these ATDs, antithyroid drugs is how you'll often see them called. I know I kept alluding to these and saying we'll talk about them later, so now's later. So the antithyroid drugs, these are really old school. Propylthiouracil, PTU, and methimazole, marketed as Tapazole, are what are used as antithyroid drugs. And basically what these do is block the conversion of T4 to T3. Again, remember I said that 90% of the hormone that is released from the gland is T4, and T4 is considered metabolically less active. I may have said inactive, I should have said less active. So T4 just floats around the body waiting to be activated by way of deiodinization. So when you deiodize T4, you make active T3. These drugs inhibit the conversion of T4 to T3. So they're not a curative treatment, they're just a controller. These really are not anybody's first choice drugs anymore. They're used for the elderly who just aren't good candidates for more aggressive therapies. They're used for pregnant women who can't get radioactively ablated. But they do have a significant side effect profile, like the potential for suppressing, white blood cell formation and making you agranulocytotic and really susceptible to infection. They're not, they're old drugs, they're not great drugs, but they are an option when other curative therapies aren't appropriate. And then the last one, I know I kept referring to radioactive ablation. Radioactive ablation is when you take iodine, make it radioactive, and then give it to the patient. So then because the thyroid gland will always pump iodine in circulation up into it, now when you give radioactive iodine, the radioactivity tags along, and the patient winds up pumping radioactive iodine into their gland, and it like nukes the gland, and it shuts it down. So you certainly won't be hyperthyroid anymore. This is why patients often come out of it having to take thyroid hormone. They give tracer doses and then try to calculate the right dose. And sometimes they do pretty well, but most times patients do wind up having to take thyroid hormone afterward. But that's okay because it's easier and safer to manage hypothyroidism than it is hyperthyroidism. And there are some patient education things here. Remember I said these folks need some education. Oh shoot, I hit the thing too fast. Sorry about that. But remember I said patients on radioactive iodine do need some education about things like how to manage their waist, other things that were on that slide, avoid close contact for like almost 2 weeks, no pregnancy for 6 months. But those are things that, certainly they are taught when they go to interventional radiology, and then you reinforce. All right. I guess now we're going to close this topic of conversation with the adrenal gland. You could go an entire career, I guess, without seeing people that have adrenal disease, so I really won't perseverate over this. But there are a couple drugs that center around this. So the adrenal glands are little glands that sit on top of the kidneys, and they make your stress hormones, and you have an adrenal cortex and an adrenal medulla, right? So we are interested primarily in the adrenal cortex. So the adrenal cortex, not that the adrenal medulla doesn't matter, but that just makes epinephrine. So there's not really much we can do in the way of drugs about that. But the adrenal cortex releases 3 groups of hormones. The mineralocorticoids, the most clinically significant of which is aldosterone, the glucocorticoids, the most clinically significant of which is cortisol, and the androgens, which are your secondary sex characteristics, right? Precursors of all of your sex hormones. So aldosterone, cortisol, and androgens. Those are the things that are released by the adrenal cortex, and when you have adrenal cortex problems, you have to replace these hormones sometimes. So diseases where you don't have enough of these hormones it's Addison's disease. And Addison's disease is primarily a disorder of not enough glucocorticoid, not enough cortisol, and not enough androgens. Fludrocortisone, the aldosterone one, that's a different kind of abnormality, although you can see it in patients who have really profound Addison's disease. Addison's disease, by the way, is autoimmune suppression of the adrenal gland. Most of the time it's autoimmune. There are other diseases that affect the adrenal gland, and sometimes, like people that have had tuberculosis can have tubercular hypoadrenalism, and sometimes people that are on Coumadin will actually get some hemorrhage into the adrenal gland and it shuts it down. So there's a few different things that can mess up your adrenal gland, but mostly it's Addison's disease, which is autoimmune destruction of the gland. And then you don't have enough cortisol, androgens, and to a lesser extent, aldosterone. So what happens? Well, we replace it. If you happen to be replacing hormone, it's probably going to be hydrocortisone, probably. Fludrocortisone, like most people do okay if you just put them on hydrocortisone. Every now and then, especially if somebody gets sick or is under a physiologic stressor, you have to replace the fludrocortisone too. So what are the implications there? Well, fludrocortisone is the drug, oh God, that fast. Florinef, right? The drug is fludrocortisone, and it's marketed as Florinef, and this is synthetic aldosterone. And aldosterone is the hormone that makes you retain salt. So if you give this drug, you are promoting salt retention in your patients. And this is actually a really powerful drug. This is often given at like 0.05 milligrams every Monday, Wednesday, Friday, and then titrated up as appropriate. But it can be very powerful. So the real important implication for you is to be on the lookout for signs and symptoms of salt retention, which really are signs and symptoms of fluid overload, because you know how it is. If you retain salt, you retain water. I swear, these patients, it's almost like now usually by the time you give it, it's because they are clinically deficient. So they're really volume contracted. They're really hypotensive and stuff. And then when you put them on fludrocortisone, they just like fill up like a sponge. When you get a sponge wet, or like a tampon is, I swear it's the thing that comes to mind. I guess it's not very nice, but just the way it kind of fills up all the way around, like the whole body of something fills up when you hydrate it. That's what happens when you give people fludrocortisone. So really be on the lookout, not just for increasing blood pressure, although, that's usually a desirable outcome. But if the blood pressure gets too high, if you start auscultating fluid in their lungs, if you start to appreciate edema anywhere, but especially in the dependent areas, or any other symptom of fluid overload, if the patient is on fludrocortisone, first thing you want to do is pick up the phone and call the physician and ask them about holding back on it, because this can happen fast. And then also, remember, this is a hormone of salt retention, so there is definitely the potential for electrolyte abnormalities, for sodium to go up. And in the kidney, when sodium goes up, potassium goes down. So there is the potential here for hypernatremia and hypokalemia. So on top of all of this fluid excess stuff, hypokalemia and all of its associated cardiac abnormalities. Now, hydrocortisone, we give this in the form of prednisone or Solu-Cortef, right? And hydrocortisone is the one that you will typically be giving to patients who have Addison's disease. So when you're giving it, you just want to be watchful for the symptoms of overload, for the symptoms of toxicity. So just think about the things that cortisol does, and if they're happening too much, then you may have a problem. These are stress hormones. They make you ready for a stressor. So hydrocortisone or cortisol causes vasoconstriction. So if the patient gets hypertensive and they're on prednisone, you have to worry about that. Cortisol mobilizes sugar as a fuel source. So if the patient suddenly becomes hyperglycemic, this might be somebody who already has diabetes or has been like on the fence of diabetes and now their sugars shoot up. If they're on prednisone, that's probably causing it. Prednisone suppresses inflammation, which is fine to a point. But if the patient like now has a surgical wound or a decubitus or something that won't heal, that's potentially a problem. So whenever you're replacing hormones, whether it's thyroid hormone or mineral corticoid like aldosterone or cortisol, you're always just looking for toxicities in the form of excesses, like whatever that hormone does. If it's doing it too much, then there's a problem. Yeah, so the patient with too much hydrocortisone on board, clinically you will usually see wounds that won't heal, conditions that won't heal, rashes that won't go away, maybe frequent onset like yeast infections or fungal infections, stuff like that. Hypertension that is persistent despite being medicated, and sugar that is going up for no obvious reason. I mean, even patients who are not diabetic and not at risk, if they're on prednisone long enough, their sugar will appear to go up, again, if they're toxic. And if you use any of these hormones too long term, you can suppress the patient's own ability to produce them, which is why, like if a patient is on prednisone or Solu-Cortef or whatever, for any significant period of time, usually over several weeks, they have to be tapered off it really, really slowly, because when you give all that extra hormone, you suppress the body's ability to make any. The body will just, because the body always tries to normalize. If it wants to have X amount of hormone on board, and the little adrenal glands are struggling and they're making some, like not enough, but they're struggling to make some, and then you come along and give more, the adrenal glands are like, cool, I don't have to do it, and they just stop working. Fine. But then if you suddenly withdraw the drug, now the patient's just got no hormone on board at all, and that's a problem. So that's all I wanted to say about that. We'll end this for the moment, and I hope it was helpful. As always, you know where to find me if you have questions.